Our meeting to order, please, and we'll pledge allegiance to the flag. I pledge
Allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you. We don't have any public. They may be here.
I don't know if you count or not. Do
Are you
count?
public?
Well, at the moment, we'll pass the public comment. Consent agenda items, anybody have anything they need to change there? If not, I'd ask for a motion. Move. Second. Move and second, those in favor?
Aye.
Aye, thank you. December, Cheryl. Financial report.
No, it's all right. You sure? Yeah. No big deal. No big deal. Is there snow? Yes, there is snow picture. So, December overall was really a repeat of our previous month. It was kind of busy, but it was fairly average. Our total patients to date is 62 less than it was last year at this time. So that is a 2% decline year over year. The emergency department was down 2%, which is quite a few patients, and surgical outpatient was down 20%. Looking at ancillaries year over year, lab was up 2.5%. Radiology is down 4%, which is surprising because it seems to stay busy. Rehab was up 21%, and home health was up 148%. They've been busy but slowing down. Our average monthly revenue is now at $2.36 million for the first 6 months of the year. It's up from $2.2 million last year. Our revenue in December was a little above our average at $2.45 million. Our days in accounts receivable went down again. We're at 78. We were at 83 last month, so that's good. Our days cash on hand came up. In November, it was 159. It's now at 165, pretty close where we were at the beginning of the year. That's good. Our profit and loss. Revenue was pretty good for the month. It's $138,000 below budget. Year to date, we're at $785,000 below budget. Mostly that's surgical revenue. We're also below in our expenses rather significantly. This month, our wages look low at $700,000 because we did discover that we had failed to back out some Lakeview Gardens wages. So we did that this month before we catch up, and those are out and they'll stay out. But that helps out our year-to-date numbers as well. Both month over month and year over year, expenses in total are below budget. Materials and services continue to be high and over budget, mostly because of temp labor costs. Our net gain for the year is now $60,000 ahead of budget after the first half of the year is complete. So not bad. Questions on Lake Health? Okay. I did put together the budget calendar. I gave everybody a copy. We are getting ready to start meeting with our managers, reaching out to our budget committee. Anybody has any comments, questions? Do they have to vote on it? Okay.
We have a budget committee, a full budget committee.
We do.
We're good.
Yeah. Well, that's, I have not checked with them yet this year. I'm going to do that by February 8th.
Okay.
I hope they will all come back. Okay,
We had a couple new members last year, and they indicated an interest in continuing, so we're anticipating that will still be the case.
it would be nice to have some continuity. Okay.
Do we need to adopt the budget calendar?
Yes. We
Oh,
do
you
need
do?
to adopt that budget calendar.
Okay.
So we have.
I'm sorry, I thought I asked.
You asked me, and I said.
I'm sorry. Oh, okay.
I'll make the motion to approve the budget calendar as proposed.
I'll second that.
Moved and seconded to adopt the budget calendar as proposed. Those in favor?
Aye.
Aye. Thank you.
Okay, now I screwed up. I forgot to talk about the balance sheet. Sorry. I was going too fast. The balance sheet, month over month, cash is up, accounts receivable is down, liabilities are down, all in the right direction. Year over year, our cash is up, our AR is way up by $1.2 million. I think between 600 and 700 of that could be attributed to the additional clinic volume, but the rest is AR that should be collected. Liabilities are just a little bit, so nothing else that is needed. Okay, so then, Goose Lake and Lakeview Gardens. Lakeview Gardens continues to see a month-over-month increase in their patient days. However, we're still down year over year by 6.7%. Oops. Oh, shoot. Revenue for the month of December was $145,000. It's just a little bit below what we, our monthly average so far this year of $147,000. Still below last year's average, of course, with fewer patients. The profit and loss for Lakeview Gardens, again, it was a very average, very close to average month. For the month, there was a loss of $17,000. The balance sheet, look, over here to the right, so we are billing out of point for care, we are making progress in the direction we need to go. So this accounts receivable now, last month, we didn't really like the way it looked much, but now that AR is strictly, truly patient AR. So that's good. Okay, questions on Lakeview Gardens? Pretty average. Goose Lake Medical Services, I went ahead and redid this graph. We are still on hold with Cahaba, so our days in AR continue to rise. We continue to call Cahaba. We are waiting their response. We still didn't hear, right?
No, yeah.
But we only have a few more days,
Well,
a
Saturdays.
week to 10 days.
On them too.
Yeah, so it's frustrating. So what I did do is just go back, now that we feel like we've got the billing sorted out, this is what the actual charges would be, is, by month, instead of showing it the up and down we had last month. I decided that's just too confusing, it's not very useful in the long run. So this is the charges that we actually created by month.
So this is actual instead of taking the
Yes.
adjustment.
Well, instead of, most of these charges have yet to be set. So this is based on actual charges, patient seen, revenue earned. Okay. Monthly average revenue continues, it's down a little bit from last year. We do have fewer providers right now than we did last year at this time. So, Tony is here. He got here yesterday, I think. They've got all moved in. He's gonna start working up here. He's working on his California license. So that will be key to driving revenue at Goose Lake. I mean, not only
How
are
long will
we,
it take him to get his license? What is that time period? Any ideas, sir?
I would think another.
Tony mentioned when he called, early in the week that they were working on applications submitted in late October and early November. He submitted his application early January, I believe it was.
We're a couple months out.
Was it November? Okay.
As a reminder, when Dr. Gilbertson started, it took us 5 months for her to get her license. They are traditionally significantly slower in California on approving licenses than in Oregon. And we're trying to encourage it through the political process, see if we can speed it up. Because sometimes they will make exceptions for rural environments.
Is there anybody with a California license that you can switch and have?
Well, Dr. Gallagher has a California license, but I don't think we would want to see him go to our clinic in Alturas.
I know I wouldn't.
Hey,
That, unfortunately, that is the challenge that we face.
it's actually nice, good clinic, not bad. So the answer to your question is we really don't know. But at least we will have him up here and getting settled and seeing patients, and that will help us here.
And he'll also be training on eClinical and getting acclimated to our organization, some of our services, all those kind of things. That'll really help for him as he practices there.
Speaking of the clinical, are you comfortable now that we understand well enough to go ahead and start it up here? And we schedule it for what, March?
We have started using it for scheduling. All of the employees are doing training. They're trying to do, Juanita has been working with all of them to try to get them into the system an hour or more a day to, become familiar with it. They are using it for scheduling. We are still arguing with the clinical about how we think it should look when it's working right. If we don't think it's working right, we're still fighting with them over it. So we're still planning on a March go live. But we're still not really happy with it. So, yeah, I think we will have to live with the way it is. I'm not really sure, but we're gonna keep fighting to make it better. Profit and loss, we've lost now 13,000 year to date, whereas last year at this time we had a small profit of 3,700. And like I said, our AR continues to grow. So, any questions on Goose Lake? When we do get the hold from Cahaba removed, and we send all those bills, they will pay us. They should pay rather quickly in a very large lump sum, so it won't take, once that hold is released, it shouldn't take a long time to start collecting.
That's all bookkeeping numbers here.
Everyone remembers the reason why the hold is placed. So when we switched from it being under Dr. Stevens' name to Dr. Gilbertson's name. So Medicare and Cahaba is the Medicare intermediary for California that handles it. Once again, they don't move very fast.
No, and I actually did receive a letter this week from Cahaba acknowledging receipt of one of the 2 cost reports. So it's concerning to me that I didn't get a letter that they received them both. They were sent in the same envelope. But I was sort of moving in the right direction, but slowly. So, okay, that's it for me. We'll have to do these.
Are we on that same one?
Yep.
Okay.
They're up.
Any other questions for Cheryl? I see we have some public here now. Is there any comments that you people would like to make?
We just didn't know if you'd have questions for us. Charlie will probably know later.
Okay, I know Charlie's going to cover a little bit. Yes. All right, medical staff privileging, we had a number of those.
Yes, I'm sorry that Dr. Hussey is not able to be here at the meeting tonight. In his stead, we sent out to you a list of all of the privileges that have been reviewed and approved by the medical staff. Would you like me to read them to you, or if you
We've
all
all
know
seen
that the medical staff agreed to accept these, and so they are recommending to you that you approve the new applicants and the renewals.
So moved.
Moved and seconded, those in favor?
Aye.
Aye. Thank you. Teresa, nursing report.
We'll have a couple things just to add. Kind of an update. I don't know if you all are aware that our longtime surgery manager, Lena Height, is out for a long period of time on indefinitely on a medical leave. So that left a giant hole in nurse management as well as surgery staff. So Tina Copeland, who's been in the surgery department for quite some time, is going to be the acting or temporary manager going forward. So she's already working on some of the different things and getting acclimated to some of the things she hasn't been used to doing. So we've started that. I also don't know if, I've talked about Megan Cruz, O'Leary Cruz, who has stepped up and is our lead OB nurse now in lieu of Kathy Burkhalter, who's leaving. Doing a great job. She's got a lot of new and fresh ideas. Today we met with the various managers of the different physician clinics, started talking about ways to improve our OB process, ways to get more people to attend prenatal classes, that sort of thing. So we're just starting that. The clinic staff were very receptive and it went really well today. So we have some good ideas. So that's good news. I did also just want to mention that we have in process, I think Charlie talked with you a little bit about some of our goals, and one of those was to improve our results of our VTE, or venous thrombus embolus prevention program. We're at about a 50% ratio right now in terms of our prevention. And so we're working on that, working with our providers, working as much as possible to try to have the informatics people work with the physicians. There's a lot of things that have to be in place in the computer in order to make that happen on every patient every time. And we do have a new measure that we are just getting ready to start reporting on, which is sepsis, which is essentially an overwhelming infection of the patient. And so that'll be another new measure coming down with new order sets that we'll be working with the physicians on. So these are all just a huge accumulation of things that the providers have to deal with, and trying to get them into the electronic medical record, as well as helping streamline all those processes and get things out of there that don't belong. So we have a big job ahead of us, but we're working on starting that. So that's just kind of where we're at. Any questions for me?
Your overall nurse supply, have you got enough?
It's better. It's better. I'm happy to say it's better. I still have one nurse that has been hired but hasn't arrived because he's kind of like our FNP. He's waiting for his Oregon license. He comes out of California, so we have one more nurse coming. We've had two travel nurses, one in the ER and one on the floor. And we probably are about halfway through their assignments, and that was also to help us cover, because we had like 3 huge medical leaves of full-time people. So we've been covering that, and those people are coming back on light duty, but hopefully in another 2 or 3 weeks that will become full duty. So nurse supply is getting better. Just got, you know, the hard hit with Helena and that sort of thing. So that area is still, we're struggling a little bit there, but otherwise it's starting to come back together. There was a lot of changes.
That's good news.
It is good news. yeah, it's better for us. Carly, who was on nights for 2 months, is back on days, so that's nice. Yeah, so.
All right,
Any other
thank you,
questions?
Trish. Charlie, DME business.
Sent out a copy of a report that we have received on an issue that we talked about over the years several times. And that is durable medical equipment in Lake County. We are serviced by a couple of companies out of Klamath Falls, and frankly, it's kind of hard to get service. Our community is not really well served the way we think that it should be. And we struggled with this. We've talked about it time and again. I think even before I got here, it was looked at. Is this something we ought to do? And one of the things that we have found in our analysis is these are the kinds of problems that we face here. There's no local provider. The nearest is quite a distance away. What that means, though, for a lot of us, our patients, is sleep level, that we have been expanding and providing much more service, getting the patients fitted, and getting them to use their masks properly, get all that out. That's really important. We want to have, we do the study based on what the physician has ordered. The physician directs this kind of care, oxygen or whatever the care that they're needing. If they're not getting the equipment to do that, the patient is not getting that. We're essentially wasting money. When we hired Juanita Trinkle, our new clinics director, who has been doing a great job helping us get organized, helping a lot with eClinical, with a lot of different programs. Her husband came with her. I'm sure that made her feel good. And he has, for the last 15 years, been managing durable medical equipment. So I asked him, what would you think? Could this be done here? And so he gave us the report that I sent out to you. And based on his analysis and his experience, it would make sense to do. Now, he looked at it and said, it doesn't make sense just for Lake County, but it would also include Modoc County. They don't have any service either, or they're getting their service out of Klamath Falls. Based on his projections, and the projections that we sent to you were with him. Then he went and talked with Krista Harrington and talked with Teresa Conklin in our sleep lab, and tried to compare notes and see if his projections made sense. And we made some slight adjustments. So as we look at this, based on using his analysis and talking with other staff, we think it would take about 6 to 9 months to get it started. It's like when you start up home health. You can't get credited until you have 5 patients. And you have to take care of those 5 patients for an extended time period, and you can't get any money for that. So you have, I mean, that's just part of the requirement to go through to get a license. And the startup cost would be buying a van, estimated $25,000, but it's a delivery van. It doesn't have to be a fancy van. That may include some other components. And one of the big differences that from our original thought process was much of the business of durable medical equipment is selling oxygen. And that's typically been done in tanks. So patients have tanks, they have to get them filled, they use that for breathing, and then they get that replaced, and that's been a big part of it. Now they have concentrators that are affordable, that you can lease, you don't actually buy them. And it's cheaper for the patient, it's much more user-friendly. They have the noise, but they can walk around their house with a cannula in their nose and long pipe. And they can take them and go different places with a mobile unit. They don't have to carry these tanks. That changed the dynamic. And that was one of the things that Kristen was most concerned about, is because the tanks are expensive to buy and maintain, and there's just a lot of challenging components.
Does that also do like the liquid oxygen systems?
Well, the way we get our bulk oxygen is in liquid. We have that available.
I mean, a lot of patients used to carry a little liquid oxygen unit instead of a tank.
I believe that now they're using these concentrators, and what they're doing is they're taking atmospheric air and extracting the oxygen from it. So that's how that's functioning. And then you have to have a backup battery, and you have to have, you know, in case it breaks, and they occasionally do, and you have a, because they're rented or leased, you have an exchange readily available, and you have an exchange within 24 hours from the manufacturer. So the process is actually better for the patients, and it's much less expensive. So you don't have as much of a capital investment in the start. So based on that, our estimate is, if we were to do this, in the first year, it would be about a loss of $56,000. But in the second year, it would break even. In my view, the most important part about this, and Michael's estimate was we'd probably break even in about 4 years. We think that because there's, by using Teresa Conklin's estimates of more patients that she's aware of that are currently on oxygen, and some of the other factors, that this would work out. And that's why the numbers changed. So I would not say that at any time are we going to see this as a moneymaker. But if we can cover our costs, it would be really good community service and a whole lot better for our patients. I think it would really enhance the care that our community is getting. When our physicians, I mean, keep in mind, just a couple of years ago, with our sleep lab program, the sleep lab study was done, and 6 weeks later, we would get a report from the specialist. And we still didn't have anybody making sure the masks fit the program. I mean, that's not good care. Now we're getting reports much more current, still not as good as we wanted. It's getting to the information to physicians. Teresa's actually doing the mask fitting, not charging for it because we don't have a durable medical equipment. But she's doing that because it's good care.
Are you sure that 6th Street Steel doesn't provide oxygen bottles out there?
They are a Norco vendor. They do provide oxygen. We're not anticipating we'll capture all the market. But what Michael estimated, and this is his experience, not mine, he said when he was in Reno most recently, where they came from, Carson City, Reno, he was approached by the vendor that we have, which is Lincare. And they said, if you would take over Susan, we'll give you all the patient business. Because frankly, it's too expensive for us to drive out. He says, I would anticipate a similar experience here in Lakeview. That those vendors from Klamath would say, it's not economical for us to drive 90 miles one way just to make an adjustment or deliver oxygen or something like that. Now, if that isn't in fact accurate, and this doesn't pan out the way we think it would, I don't think we would want to continue to try and lose a lot of money. I mean, that would be dumb.
Are we going to be storing the DME in your office, or, do we have a spot for it?
Well, there may be opportunity for crutches and walkers in my office, but we do currently have a lot of supplies or support equipment that a lot of our home health patients, we lend them to them, and they're all stored right now at home. So I don't have all the answers yet, but we think that another good advantage to this program is that if we have the durable medical equipment here and people come to buy a wheelchair, buy a walker, buy crutches, they can pay for it and have their health insurance cover it. versus it being out of pocket if they shopped elsewhere. That's a huge benefit to people that need these appliances and may not have the cash, but they have the insurance coverage.
Would you anticipate serving Modoc County out of here or out of down there?
That would be our expectation. But I don't know for sure, and I think it depends on how well they operate. They're essentially the same as us. I don't think we would want to invest in another vehicle. We certainly don't want to have more staff. We have to. So we're trying to do this as economical as we can.
Charlie, before, and this is before, meaning at least 10 years ago, we require, or the requirement was we have a storefront. Is that still a requirement?
But the requirement is that we have to have somebody available during the day, during our normal business hours. One of the advantages we have in our home health office is that we have staff in that office all the time. And so we could make that available during normal business hours. And so one of the things that we've talked about is if we make that our storefront, if you will, where we could have somebody available to buy and sell the crutches or implements, depending on what that might be. That would be a great way to do that. What it would also do is if the doctor sees a patient in the clinic and says, you know what, you need to have, you hurt your ankle, you hurt your knee, you need to get a crutches right now. We can get somebody to get that over to you right now and get the fitting right. It provides a much better service for our patients. And I think that would be a really good benefit.
Do patients have to buy the equipment? Can we rent it? Can we lease it?
I don't know all the answers. And there are some people that cannot afford, and so we give them those things. I would expect we would continue to do similar kinds of things. That, you know, we are about service. So,
Charlie, I know that the senior center is also kind of in the giveaway lending business with some of this as well.
right. And, I mean, that's part of our community. So it isn't that we're necessarily going to be selling a lot of these crutches or walkers and wheelchairs. But those people that want to buy mechanized wheelchairs, we could make arrangements for that. We could provide health, we could arrange for that and make it much more convenient for those individuals. And rather than having to drive to Klamath to do that, we could accommodate that. So there are kinds of things that we could do that aren't available now. But we certainly don't want to try and make it difficult for the senior center or other places to make that available.
Charlie, is the $42,000 figure up there equipment costs? Does that include oxygen?
Well, part of that is leasing the
Oh.
concentrators, because we would have to release the unit. We're responsible, and then we lease that to the patient. But we are the arranger of them. We would purchase the oxygen supplies. We would purchase those crutches. Some of the crutches that we have may not exactly be appropriate for people or walkers or whatever. So we would be buying some of those supplies.
Would you lease out hospital beds?
Yes. According to Michael, there's not a lot of call for that. Generally, you don't lease them because they don't break. They last for a long time. Generally speaking, you essentially sell it to them. And the Medicare pays for it over time, and then it's theirs. So it's an opportunity that we have not taken advantage of in the past. And I think that the greatest thing is that it would benefit our community. So I'm recommending that we give it a try. And if it doesn't work, if it doesn't meet like we're thinking, and we think we're fairly conservative, we'll come back and say, you know what, this was not a good idea.
Well, the projection on the paperwork that you sent us was that it would take us about 5 years to break it.
And so we updated this information.
really underestimated the number of people at the CPAP machines, apparently.
Well, I noticed the numbers included Modoc County, some folks a number out of Modoc County.
So one of
Yeah.
the processes in going through this is, first you have to get 5 patients, deliver service. Then you come out and get certified. You still can't get paid for a lot of things, so that's part of the process. Once you get that, we're licensed in Oregon, and we apply to get a license in California. Relatively straightforward process, and he's very familiar with it. Somebody having done it for 15+ years, I believe they do know what they're talking about.
Charlie, could this be included in the budget process, you know, because I saw numbers 2 days ago, and now I'm seeing different numbers, and so I know it's a good service, but at what cost? See,
So here's the answer to that.
okay.
One of the reasons why we're bringing some of these things now is the preponderance of the cost is going to occur in next year. But we've got to get started. And if it takes us, he's estimating 6 to 9 months just to really get started. So we're essentially paying for his time to get it started, but in 6 months, by that time it's next fiscal year. So we would be putting that in the budget. So some of the things we're talking about tonight are really forward-looking. And that's why we are bringing it here. And we'll get better numbers as we look into this more.
Because at first I was looking at, okay, do we want to subsidize it for $150,000 when you add it all together? And that was 2 days ago, and now we're looking at
No,
something
it was
different, so.
And the reason for the 100,000
Yeah.
was for, he was thinking we were buying all of these expenses up front.
I was curious if that $100,000 included the vehicle.
It did,
It did?
yes. And you remember, we would capitalize a vehicle. So, I mean, there's a lot of things that, when we looked at it differently, he gave us his projections, and his projections are, he knows much more about the cost. Didn't know necessarily about all of our volume, that's why he went to talk to other people. But
Does this fit under the critical access cost reimbursement program?
good question. Not exactly. It is still considered a separate business. If we housed it in one of our, like in home health, it wouldn't get special reimbursement, but it would continue to be a part of our cost-based reimbursement. Not all these expenses are considered cost-based reimbursement. And so we can't exactly put it in the rural health clinic, or it would be a separate business, probably a Goose Lake business. But what Moss Adams said is their expert retired, and so they're looking for another expert to give us more advice. So, I mean, we're asking a lot of different people about how do they think this might, what is the best way to structure this so that we maximize that reimbursement.
I had a hospital about 5 years ago that I did the software for, and they tried B&E for a couple of years. They finally dropped. I don't know if they made money or lost money, but it didn't last.
It is possible that this might not be something that we want to do, but if we could provide a good service and not lose money, wouldn't that be in our community's best interest? I mean, that's really how I'm looking at this.
Well, but I'm hearing 2 words here, I'm confused now. This is not a service, this is a business, is that correct?
Sure. But it's providing a much-needed service.
Yeah, I understand that, but it can't just be a service of the hospital without it being a
A
business.
department, like.
A department of the hospital?
Or a department, yes.
It would be licensed just like our home health, which is a separate license. So it would be treated as a nonprofit business affiliated with the hospital.
Nonprofit, so we're expecting that at best we would break even.
Nonprofit means that we don't pay profits to any
Right.
shareholders. That doesn't mean that we can't use those as profits to either expand the business or to supplement another business. Is that
Nowhere
correct,
in,
Don?
nowhere in the material did I read where it probably would be a profit, it would probably be a break-even type service.
That's how I'm approaching it. But it would also be a good supplement to our sleep lab business. It would be a good supplement to our rehab services. And it would be great for providing better care to our community.
I guess I'm not disputing that part at all, I'm just wondering about the cost aspect of it, and just kind of a 2 days to try and sort through it all, seeing a lot of different numbers and figures.
I think Charlie Reeves wants to fine tune this if we want him to go forward. That's kind of his question.
The reason I sent you the bigger proposal is because it, you know, frankly, just didn't spend a lot of time trying to do this. This is a startup venture. That would be my view. And is it worth it to have a person work part-time to try and start this up? And if it looks like it doesn't make sense, then we pull the plug. That's how I would view it.
I think that if we hadn't had two sets of numbers, I don't think we would have been more willing to jump a little faster. Is there a way to give us a little more assurance that these numbers are more vetted?
Well, what we did was this was given to us about 3 weeks ago, 2 weeks ago. And we took the findings after we had talked to different people and changed the revenue based on it. And we changed our expenses. Now, granted, we don't know enough about it to say I'm absolutely positive. But frankly, you can't add a whole lot more expense
No.
into this.
And I can tell you that, so what I did is I took his numbers, and he said that 35% of the business was gonna be CPAPs, and that he had lowballed that by more than half. So I took 35%, or his revenue number, and I said, what's 35% of it? Okay. And then what if I increase that number by 40%, so almost, almost double. And so I took that number, and then what I did is he had a number, and it said, the actual cost, the direct costs are a percent of the revenue. So I used that percentage to come up with the direct cost, so I changed the revenue, I changed the cost. And then I actually increased the wage expense a little bit, because I thought we talked about what this wage rate would be. I increased it by 25% to cover benefits, which should really be adequate. That's where I put the wage number. Now, he also had included almost $12,000 a year for rent and utilities. So that is just, not going to happen. If we put it over in long-term care, that's what I meant, over there, home health. There won't be rent, and certainly utilities aren't going to be $5,000 or $6,000. I mean, you're going to add a little electricity, maybe a phone line, but there's not a lot of money there. So that's where I reduced the expenses, and all the rest of his numbers I left just the same.
He put, the one thing I read in there, he was estimating the part-time use of the respiratory therapist at $25 an hour. We pay a lot more than that, don't we?
We have a respiratory therapist in Teresa Conklin that's doing that.
Right.
So that's an expense that he had estimated, because that's what it would cost, or something, whatever he estimated. May be different from what our current is, but that's a cost that we already obtained. So that's how we.
And absorb the work without adding overtime or.
Charlie, I think offering DME to our community is a good thing. I really do. I think that saves a lot of money, could save travel, could save accessibility. There would not be any competition, would there, between Lake District and Lincare say in Norco, they would drop out of the picture?
You know, based on what Mike has said to us, his experience, most recently in Reno Carson area, is they walk away from it as fast as they can. Their experience is the bigger companies say, frankly, if you want service, come in to us, if you're a rural person. They are not interested in paying those expenses. So will we have competition? I don't know the answer, but our speculation is that they would probably be very happy to give up that expensive drive.
Would it be practical to talk to them?
I'm not gonna talk to them until we say, let's give it a go.
And I
And
hate saying let's give it a go until we know some more things that are out there that we should check.
I
And
guess I
that
could-
being a huge one, what I don't want to see is happen is us to go into business for a couple of years and say, oh, this isn't working, and then we drop out and then try to get those entities to come back.
I can tell you that Teresa Conklin and I have spent a lot of effort trying to get better service for the sleep lab patients and the CPAP fittings and follow-up. It's been a very difficult path. We started off meeting with them. We still have some cooperation from one of the DME companies and almost no cooperation from the other one. And in essence, she does a lot of their work for them, because if she didn't, it wouldn't get done. Certainly not in a timely fashion. So we have explored other avenues of having DME just for the sleep lab. We actually had a company in Medford that we thought was going to work with us and we would be their storefront. And they ended up sort of folding and dropping out and not following through and that kind of stuff. We've tried repeatedly to work with the one company that does come here frequently, which is Lincare. And we've asked them if we could be their storefront, you know, what could we do? They are corporate, they're big, both fairly large corporate agencies, and they don't get their corporate approval to do it. So we've gotten nowhere, absolutely nowhere. So we've tried to get them better, you know, work with them to get better service for our patients. And I mean, essentially the field is wide open if they wanted to take it, and they have not.
I'm concerned that your equipment costs are going to be higher. What you have to buy inventory.
well,
I don't know what Michael's plan is, but I do know that PacMed was here not long ago and saying, we want to be your DME provider. And they don't make you buy anything until you sell it. So they stock you with inventory, and then as you sell it to the person, they bill you for that, and you bill insurance or the patient. So I'm sure, I actually think that cost might be pretty overstated, personally.
If they're consigning it, sure.
Yeah. And they're very interested in working with us on that. Yeah, which is nice, because we can't really afford to carry a big inventory. Also, to not have things, you know, we don't want to buy stuff and then decide 2 years later we don't need it. So if we don't own it, we just send it back.
That's a big factor in my mind, if you're not going to have to buy the inventory.
Yeah.
that's the principle behind this, which is different from the strategy that we've had in the past, or thinking.
You know, I think I'm pretty much all for it, for providing the services. It just sounds like we need to tie down a few loose ends, questions about the inventory. Just get them a little bit more assurance for us going forward. I think you need to do a little bit more investigation, and if we don't have to buy the inventory, if it is as you believe it is, you know, if we get better assurance on that, I'm all for it.
Yeah, it's going to take a little time for Michael or somebody to tie all this stuff together and make,
Mhm.
have a a proposal from these companies.
Well,
They'll provide us.
then if it's all right with you, what I'll do is, because right now, he's been doing this without pay, helping promote this. We'll engage him to help come up with far more specific, and come back.
Like you say, it's a business, just come up with a business plan.
Yeah, that'd be good.
Well-
Nothing magic about it, yes. Yeah.
I understand, and the reason that I brought it up now is, I think it's important for you to understand what, we've talked about these kinds of opportunities in our strategic planning discussions. And I want you to know where we're going on some of this.
Well, it's also a good timing for a budget item, a line item.
Yes. That's
Absolutely. And that's another reason why now is the time that we're bringing these items.
We will have a auditor meeting about mid-month, so you can get it by then, you know.
Certainly,
If we can get the auditors to move on it.
we'll keep working on this. Thank you.
Thank you. Let's see, activated. Compliance.
A compliance report is required periodically, so about last summer, I think, I brought you a report. So here's the follow-up to that, and a report on 2015 and what's expected in 2016. If I can use it, what I do, Jen, just hit this arrow or the space bar. So in a nutshell, some people are new and some people are, you know,
Don't look
here
at
are
me
the
when you
7
say that.
problems that we got through. No, what I'm saying is, you know, briefly, there are just 7 elements to the compliance. It's, you know, compliance is all about your, if you're following policy, rules, and regulations. So compliance is about getting your policies, procedures, and your code of conduct. It's about having a requirement met of a compliance officer and a committee. You have to educate the workforce on compliance. You all have had to have compliance education. There are things like the Stark Act, anti-kickback, those kinds of things, fraud, waste, and abuse. All that's required compliance education. You need to have a hotline for reporting within your facility. It's anonymous. You need to do monitoring, auditing, and risk assessments to make sure you're in compliance. Otherwise, how do you know? You need to have enforcement and discipline when there are violations. These are all required by the government. And you need to have a prompt response and corrective actions. You have to be able to prove that if there are reports. That was it. That was your compliance overview. So
When you say the government, are we talking about Oregon statutes or federal statutes?
I'm going to tell you right now.
Okay.
Thank you, Chuck. So here are just some of the agencies that we have to pay attention to, or I have to pay attention to. Of course, there's Medicare and Medicaid. Medicaid being the state, Medicare being federal. With that, they're really focused on revenue, fraud, waste, and abuse, and the other 2 laws, legislation I talked about. And there's a lot about regulatory compliance. So from that, the Office of Inspector General puts out an annual work plan, and they require that we do exclusions. You'll run every employee, every physician, everyone through an exclusions list. Those are people who have been booted off of being able to receive any kind of Medicare, Medicaid funds. So you can't even have them in your facility, essentially. If you're excluded from Medicare, Medicaid, it's kind of a death knell. We have the Office of Civil Rights, which is they're the policeman for the HIPAA and the HIPAA security rule. The security rule is the electronic arm of HIPAA, privacy. We have OSHA, which is the workplace workers. We have to make sure that we're protecting workers. And now with the rural health clinics, there is the rural healthcare clinics.
there's a national organization that puts out guidance that we have to pay attention to. So in 2015, and there's more than this, but I'm going to give you an update, or actually Brian is. I came to you and said, we know this is one of our problems, the one in red, claims denials. There are other things that CMS really wants you to look at. They want you to do charge master reviews, and that gets done through the business office orders that. It's an outside agency that comes and reviews our charge master. And the PEPR reviews are, that's an electronic payment report. So that's another source you can use to see if you have anything that's out of line. It shows if there are abnormally high billings happening in a particular area. We have chosen, Brian and I have chosen claims denials. This was a new committee that was started in 2015. Remember back, it says you're required to have a compliance officer and committee. Well, I have 3. So we're covered on most of those things. But the claims denial has been an interesting process, and I'm going to let Brian talk about that. I think we've got your graph next.
So in June of last year, we selected ER denials, and these are denials because the insurance is not covered on data service. So every month, the insurance information isn't correct on the data service. So when the insurance information isn't entered correctly into our system, so when we receive a payment from the insurance company, let's say Blue Cross, the insurance company gives us a denial because it wasn't paid. And every month we track our denials, and number 7 is insurance not covered on data service. That's the denial number. So there's different codes on an EOB, and every code represents a denial reason.
So we just resubmit with the correct?
Resubmit with the correct insurance information.
But it delays payment.
Yeah, delay pay. I understand.
So in the ER, in June, we started verifying insurance. The unit secretaries started verifying insurance. And we had from June till now, because of that, we had a 33% decrease in denials. The red line is 2014, the green line is 2015. We don't think that that was successful enough. And for 2016, we're going to have a dedicated person verifying insurance in the ER at the window. So from Monday through Friday, 8 to 5, we're going to have somebody verify the insurance. They can ask, or they can fill out financial assistance to the patients in the ER.
They'll be in the ER physically?
Yes.
Okay.
And the issue is the insurance presented is invalid. Why is it a denial?
Well, a lot of times, people have Oregon Health Plan and then they switch to EOCCO. I mean, that's very common. That can switch month to month, or in their plan renewal, they select a different insurance company and we don't ask them for the correct information. So if we verify at time of service, it's a lot more accurate. And the unit secretaries are kind of spread pretty thin between the ER and acute. This will take a little bit of load off of them.
They still
do a double check at night, or will that be done, that won't be necessary anymore?
I think we can work that out. I think the person, the dedicated person will make sure
Do
that.
most of it.
Do most of it. We'll make sure the information at night is complete. So we'll have some quality check, double checking on data entry instead of, so we'll have an audit process.
So I'm hearing that this person will help relieve a little bit of the problems with nursing when they're
Yes.
running around, okay?
Well,
With the unit secretaries.
just with the checking of insurance, they won't be acting as a unit secretary at all.
Okay.
No.
Is that what you were asking?
Yeah.
No.
Okay.
Well, they'll relieve some of the financial aspect of the unit secretary. So financial questions, the unit secretary sometimes has to deal with people wanting to pay co-pays. It'll be a good separation.
What percent of the ER visits are during that time frame?
Gosh, I don't know about the percent. I would say, I mean, typically, we're seeing 11 to 15 patients in a 24-hour period. The majority of those come in somewhere around 10 till 8 p.m., 10 a.m. to 8 p.m. Or so, 9 p.m.
I'm just wondering if we're gonna catch enough of them, was my question, Brian, because most of the people seem like do ER when they can't get in to see a doctor. So that was the reason for that.
Well, this
Will you be able to
person,
review an adequate number? during that
this
time frame?
person could review the last 24 hours, and the
Okay.
claim won't be generated until they verify the
Okay,
information.
good.
And this will continue, this will be an ongoing project, but then we're already talking about the next department that's got a high number of claims denials. So we'll start chunking away at those.
Yeah.
Can you electronically verify insurance too?
Yes, our system, CPSI or Evident, has a interface with most insurance companies. So the data within CPSI can interface with the insurance website. So you press a button, I mean, there's a few steps in that process. The insurance companies are not connected to our eligibility software, we have to go to the website.
We can go to the website, not a phone call.
Most of the time it's a website, sometimes phone call. But we had an update in our software that included, I'd say about 40% of more insurance companies within the last, that was 2 months ago.
So that was one committee's activities for 2015. We also have a few other committees that are working. One is the regulatory committee, which is a new one that Teresa, Sheila, and I started in 2015. And what that committee does is policy reviews and rewrites, updating, and of course it starts in acute, and it's not a fast process. You know, it takes a lot just to do, and there are so many policies. And partly because of that and other issues that we have a policy stat, which is a software that we've gotten and are implementing. It's an electronic method of accessing our policies. So each department is busy sending me all of their policies, and there are a lot. And they're slowly getting, I'm the bottleneck in that process, they're slowly getting uploaded to the site. Once that happens, then it becomes a more automated process. policies are supposed to be reviewed on certain periodic basis, sometimes a year, sometimes as long as 3 years, but they should be reviewed periodically. And this will help us with that. It tells you where the policy is in the process of being reviewed, if there are 2 reviewers or 3 reviewers. So that's gonna be enormously helpful. Once we get that going, it's just taking me a while to get it all uploaded and running. So that's what this new committee does, is a regulatory review committee. The OIG is another watchdog, if you will, and just the items in red are items that we're actively working on right now. OIG offers guidance documents. If you're a home health agency, if you're a hospital, if you're long-term care, you need to be looking at these things. We think that we kind of know that. I think I kind of know that already. And then they put out an annual work plan, which many hospitals actually use as their guiding Bible for the next year. So they look and they see what OIG is going to be looking at for surveys for the following year, and they use that as their document. We have limited resources and limited time, so we pick our own priorities. We don't necessarily go by what the work plan is put out by the OIG. And the Office of Civil Rights, like I say, they're the HIPAA and the Security Rule Police. We've had this committee going since 2012, and that's been another, that's been a painful committee. The security rule is all about electronic transmission of protected health information. So you have to do a risk assessment, you have to put in policies in place according to what your risk assessment revealed, and you also need to make sure you have contracts correctly in place, and especially with your business associates. So that's ongoing, it's slow, but it's ongoing. That's what 2015 was yielding. 2016 is going to be, more of the same, plus OSHA. Remember, there's the OSHA compliance for worker safety, and we've already asked them to come and do a consultation visit. They've done one, that was a safety visit. They gave us a long list of helpful information, and much of it was centered around maintenance issues, and they have corrected almost all of their, all of their serious items have been corrected already. Then they had some that said not so serious. That's actually how they worded it, not so serious. And those are being looked at. Many of those have also been corrected though. We have 2 more visits coming in February. In fact, I think it's next week. And they'll be doing a health assessment like air and chemicals being used, maybe in the lab, laser gases, things like that. And they'll also do an ergonomic audit. Last time they were here, they did one in long-term care. We're going to ask them to do an ergonomic audit this time in acute, because you guys didn't get it last time. It'll be helpful. And then these audits that they do are enormously helpful. We should have them out a little more often. So there will be follow-up work from that. There is going to be the rural healthcare clinic, a little bit more focus on them this year, now that we have a great clinics manager and things are moving along. Compliance just needs to make sure that they've got their policies in place, and that their program evaluation plan is ready for an audit if that happens. And then the CMS, of course, we call them the COPs, conditions of participation. There's external peer review, which we do, and need to bump that up quite a lot more, because there are a certain number of records that should be sent out for an external peer review every year. And also, whatever the results of our last survey, we need to follow up, make sure we're still doing what they told us to do. So really, that's it. I mean, if you have any questions, I'm happy to try to answer them.
I have a question for Charlie. Last board meeting, I think it was, there was a mention that you're expanding lifts in the acute care. Is that correct or not?
budgeted, I think we had 2 lifts that we added. So lifts are a classic example when we look at ergonomic issues. Are we making sure that we're protecting our employees as well as protecting patients from falls? They're expensive, so we can't just unilaterally add a whole lot of lifts.
Are these portable lifts?
They're designed to be installed into,
The track?
originally they were in the ceiling, now they're being installed attached to the wall so that you can lift patients and guide them predominantly to the restroom, because that's the most frequent place they would be needing to be lifted, if not onto a bed or onto a gurney or to a wheelchair. Right?
We did, that was one of my goals for the last year and this year, was to decrease lifting. So we did add one ceiling lift last year, and 2 are budgeted and should be, the install should start in about a month. And we have 2 more rooms going with that. And then physical therapy and acute shared not a ceiling lift, but a floor lift that we purchased that helps patients walk. So we now have 4 different floor lifts for different purposes. Turning, standing, complete lift out of bed, all of those, we have those kind of lifts, and a variety of slings. We've really expanded the types of slings that we have that would help the nurses. For example, you can lift a leg or turn them using the lift, so it is possible to not do nearly as much as they used to have to do, to try to avoid back injuries, obviously. So it's a lot of things. My problem is we're running out of storage space because they all take a lot of room. So now one of our patient rooms is filled with lift equipment. But at any rate, yeah, we've been working on that for several years. But amazingly, the staff really love the ceiling lifts. So I'm really happy about that. They love the ceiling lifts.
Yeah.
So I'm happy about that because I don't have to, you've got to use the lift. They just they do it. So.
And keep in mind, we've also had a reduction in our insurance for workman's comp.
Right.
Largely because aside from the economic value, it is enormously beneficial. There are lots of people that hurt their back lifting patients. And as a society, as we get a little bit bigger, that means that employees can run the risk of being harmed more. And if we can protect our employees as well as the patients, and we can focus on our falls, we can focus on all of it, that's really important.
Yeah, that's a big ocean. Yeah.
And it's a patient care. I mean, that's the most important thing.
Excellent. Thank you, Teresa. Or, Patty. I'm sorry. Both of you. Let's see, we're going to talk about employee nurse recruitment and retention.
Once again, this is discussion that we need to be thinking about as we're thinking forwardly. I've sent you some articles about how it's becoming harder and harder to recruit. It isn't just Lake County that has trouble. Some of the bigger urbans that have postings of 600 plus nurses they're looking for right now. It's going to be a bigger and bigger issue for the country. And people in urban settings are more prone to stay in urban settings, and we struggle trying to find people to come out here. And one of the articles I sent you was how some of the hospitals are doing things to try and not only recruit, but to encourage people to stay. And as we think about budgeting, I'd like to have some of your thoughts. Linda has been working on some ideas of what we could do to encourage people. Melinda has come up with some suggestions. Some of the kinds of things that we have not been doing a lot of, but we ought to consider, is rewarding a person who recommends a friend to come out here. A finder's fee, if you will. Some of the suggestions, I thought a very creative suggestion was to work out an arrangement with the university for some of our technical staff, nursing staff, could be any of the clinical staff, to go and spend time at another university, either to enhance their skills or do something else to help their interest in their profession, over and above what we already do. And we do a lot for our staff. We have relied in the past on our Patricia Gainey grants for helping people improve themselves. Maybe we need to think about enhancing that and finding other ways that we can recruit and retain people here. Because I believe it's going to, in the next 5 years, it's going to get tougher and tougher.
Patricia, any fund, do we add to it? Or is it just a fund that's gonna deplete if we use it?
It's a fund that is being depleted, and we have not added to it.
Because it's right about 900,000 now. I saw that in there.
It's not quite,
I don't think it's that high, but I don't recall what it is. I'm sorry.
but we have not been actively seeking people to make donations to them. I think more than anything else, lots of donations, or those people that are interested in making a donation have been more focused on other trusts, one being the Collins McDonald, which has been fabulous, or a community support. But we've got to think of what we're doing, and as we're working on our budget, if you have some ideas of what else we could be doing to encouraging retention and recruitment.
Patricia Gainey's dedicated to nursing. Right?
It is, yeah, it is.
So there's probably other areas that need some stimulus, like,
Oh, sure. If we want to encourage our physical therapy or lab or radiology, that really doesn't fit. We have done lots to help other people, but maybe we have to do more.
We've often talked, when it comes to recruitment, about housing in our community. Does that continue to be an issue?
Absolutely, absolutely. Linda could talk about that.
Yeah. That's a problem.
Yeah.
Rentals are, luckily, we have people who call us that don't advertise and tell us they have some,
Oh, do we?
which is very nice. And they're always pleased to have a hospital professional. But it's becoming real challenging. And the challenge is people say, well, I looked on the web, on the internet and searched houses, and you don't have any houses. You know, as a community, that's what their view is, and that's spooky. Because that's very discouraging. I always tell them we'll help you, and we do help them find places, because we do get a lot of people that call and have rentals. But a lot of the really nicer homes sell right away, quite frankly. You know, nothing really, I mean, there's a lot of houses for sale, but not necessarily ones you'd want to buy. So housing is a challenge.
Do we pay moving fees?
On some professions, not everybody. But what we do is we do it like we do some of the sign-ons for nurses and that, we tie them to a 3-year obligation. In other words, we will help you with this moving in this amount, if you, provided you sign this and you remain for 3 years. If you leave prior to 3 years, you'll have to pay it back. And it's an inducement. Well, and you realize it makes them think, how serious am I? 3 years is not a huge amount of time, but in 3 years, they also receive a 10-year longevity bonus. I mean, we kind of do some things that encourage them, induce them to stay. And then if you stay 2 more years, you get 1 to 5 at the 5-year mark. So, you know, but it's becoming more and more challenging.
In the nurses' training, do they go through some kind of rotation in other hospitals? Is
I'm sorry,
In their education.
there- in their education?
In nursing school?
Nursing school, right.
Well, typically, in a nursing school program, you do go through various rotations. So yes,
Is there
I
a
mean,
way,
usually it's several hospitals.
is there a way we can encourage they come here for some of that?
Well, the plan, of course, is for the KCC program
Right.
to come here. And in the past, local people that wanted to do their last rotation, if they were in the OIT program, the 4-year program through OHSU, that program, they have been flexible enough to allow our own people to come back and do the last portion, but it's just their last term. They've been able to do that clinical here. You know, we have certain things that we can't offer that they need, and then some other things we do offer. So, yeah, we can do that. We can't handle a real large amount, you know, large volume, because, I mean, we don't really have that many nurses to put students with or that many patients. So we couldn't ever have a large volume. I don't know that I answered your
Trying to
question
think of ways
exactly.
to get people on the
To
ground
come,
here.
yeah. I honestly, if we could encourage the social aspect in our town so that people who are single at the schools met people who are single at the interdepartment agency, I'm deadly serious.
Yes.
At the hospital, there's more, you know, there's things going on, but it's very difficult for someone who's new, who comes to our hospital facility and doesn't know anyone and doesn't quite know how to find the other single people to hang out with, you know. It doesn't even have to be necessarily romantic, it's just some type of
It's the same
connection.
issue at the school.
I
too,
know, I
Teresa.
knew you
Those
would-
single people
yes.
just stay a couple of years and then it's like, out
It's
of
very
here.
difficult. Love the hospital, but, you know.
So isn't there a mixer opportunity
Better get the
there?
chamber
Hook up with
involved.
the
So, Teresa, do we still have high school kids coming here on
Mhm.
rotations through Bobby's classes?
Yeah. Linda, according to
And
that.
so we're creating some medical interest through those kids.
There are a lot
lot.
of kids that
That's
have
Bobby's
pursued
program.
careers because of that.
Yeah.
It's
And-
amazing, quite
We
frankly.
get people back.
And I would guess that
We get people
you
back.
people back,
But the percentage isn't that high.
isn't it?
I would say that we probably,
Quite a few of them go on, but they don't all come back here.
yeah, the percentage
But-
of comebacks.
Yeah, it's still been, I mean, I'm quite shocked at how many of those kids. Bobby has a real good, she's very good at really knowing who's truly interested. And the nice thing is they develop their interests here. They see something, they either absolutely don't want to do that, blood, or, you know, whatever they're seeing.
Sure.
Or they want to do it, they love it.
Yeah.
So it's real helpful. But I mean, there's, they rotate through all the departments
Oh, do they?
of the clinical areas. We keep them in the clinical areas more because that's really what they're interested in.
Well, good. We
It's a
need to
great
keep that
program,
going.
I mean, you could look at some kind of a way to sort of indenture them, you know, to come back. Well, I mean, as far as saying to the youth, saying we'll help you with your education.
Sure.
Yeah,
If you want to
sure.
come back, I don't know if that was the right term, but you know what I mean,
Yeah.
in terms of, we want to support you and we'll help you through school, but we need you to come back for whatever, so many years. That's certainly something that's been done other areas.
And that is a different approach than the Collins McDonald approach, which has been, we're gonna help you, if you come back, great, but that isn't a requirement. So as we think about, as you're thinking, if you have great suggestions, or any kind of suggestions on ways that we can think about, that we may not have thought about, to encourage or induce people to want to come. One of the recent findings is that for younger people, if they can't fill out a job application on their smartphone, they're not interested. If it can happen quickly, so there are things that we have to do to make our application process work better for those individuals. If we can get them just even thinking about it. We lose people saying, I wouldn't even consider coming here because they can't find a place to live online. And they just say, I'll look someplace else. And yet, if we can talk to them, we can explain what we do have places. And we can. So, as you think of those things, we'll be probably adding that kind of item in our budgeting process.
Good.
Okay?
Thank you. Employee recognition.
We have lots of really good people. And we have recently been recruiting some new people. And we're excited about the staff that we have. And we're staffed with people that have been here a long time. And sometimes we get new people that are just really doing well. And one person that has come here, everyone has said, this person is just plain sharp as a tack, really helps patients, gets along enormously well, and it really helps our patients get well better, quicker than we anticipated. She's our occupational therapist, Leandra Vergel.
Good.
So very pleased about how that is really adding to our rehab department. And she is just really doing great.
Thank you. All right, CEO report.
We have lots of things that have been going on. Yeah, I know it's only been 3 weeks since we had our last board meeting, but many, many things have been happening. The day after our meeting, I was up in John Day. We talked about not the standoff down here very much, but we did talk about between the hospital CEOs from Pepper, John Day, and Harding. And we talked about what would happen if we were to do something like the JPA that we have in California. All of them thought this would be a marvelous idea. And so we have committed to starting a sort of monthly meeting to talk about how we can work and share services or improve the services that we're offering to our facilities, and that impacts our hospital. Two of the areas that came up immediately was, what are we doing about our quality program? What are we doing about our compliance program? Both, or the other three hospitals, all said that they have been impressed with what Patty has done as our compliance officer, and they've seen a little bit of what Patty has done when she was doing quality also. But now when we talk about what Nam is doing, they're all interested in hearing more about how we can work together to provide that service. And that's just the first. So I'm excited about that possibility. Based on our strategic planning discussions, where we talked about a lot of different kinds of ways that we can work to enhance, where do we see our hospital, our district providing service to our community. We talked about the concept of transportation, services that are taking our patients or our community members from Lakeview to another facility. If you recall, we talked about how the numbers of times that patients need to go to the hospitals in Medford or in Bend or in Sky Lakes and Climate Falls. And so Don and I were able to meet with the EMS board, some of our representatives are here, to talk about how could we work together. I thought it was a really good conversation, and hopefully a timely conversation. We tried to make it clear, as we have talked about in our strategic planning meetings, that we're not in the least bit interested in overlapping the service that our wonderful EMS services do, but rather to talk about providing that service of non-emergency transportation to and from communities. That also follows in with where we think this expansion of swing bed program, the post-acute care program that I've talked about, because we need to be able to get patients to and from our facility for them. John, if you want to add anything more to our conversation.
No, it was very positive. I know that they have some great ideas as well as to how to, if we do go ahead and build something south of here to house our transportation facilities, and they could dovetail in as well. And I think it's just going to take a longer planning to maybe integrate and help them, but for the time being, the transportation, I think, will really kind of complement what they're doing already. I don't know, do you have some comments on that?
Well, I think that it was, excuse me, an interesting conversation as well. I think that your board and our board both have, we're forward-looking and trying, and it is all patient care, doing a better job, and so I know we're all looking forward to getting with you again. We've got to get another meeting scheduled and keep the dialogue going, like, and see if we can't make it work.
This just won't happen overnight. It's going to take some time.
Right. We had planned to have a meeting on the 17th, but unfortunately, I was asked to go to Salem and talk with some of the legislators about that very issue that we've talked about, that I've talked about several times, the rural transformation effort and the monies that the Oregon Health Authority and the Oregon Hospital Association is actively trying to get funding for. It's about $10 million, if you recall, we talked about that. So we're going to try and set up another meeting with the EMS board and talk about how do we keep the dialogue going and what can we do? How do we work together? So that was, I thought, a very positive opportunity.
There's just going to be a huge learning curve because, like anything else, state standards and EMS and hospital do not interface really well, believe it or not, because you're basically mandated and regulations are basically totally separate. And so when you try to mesh the two, which other hospitals have done and have done successfully, but you have to have somebody on that EMS side that understands that EMS law because it's very sticky.
I think one thing that you guys suggested that I thought was really good is that if we hire somebody between the two of us that is skilled in the EMS department and we can share, that things would integrate much easier if we have someone that knows the language and knows the rules. And you're right about that. Some of it's pretty sticky.
It was very clear to me that we know very, very little about any of the transportation business or even the affiliation. And we're not pledging to be experts on that. But the idea of possibly hiring somebody that is to help us through that process was really a great suggestion.
We have a position open, one of our paid positions are just your secretarial stuff open now, and we are going to advertise that position with the thought of of this person that might work for us. We'll see what comes up. It might not be a easy position to fill, but that's the way we're gonna advertise.
Yeah. We're skilled at finding positions that are not easy to fill.
Yeah.
Something.
At least we work at it, because it does take time. So I think that that was a very positive thing, and we look forward to continuing that discussion. We had CPSI here last week to talk about some of the ongoing problems. And all we can be is hopeful that we will continue to work on fixing those things. Some of these take a long time to work on, but it was good to get after that. One of the things that we find in that process is as we look at multiple different software programs, CPSI, eClinical, point of care for long-term care, and the other program, the T-System, we are struggling with our informatics process. Our informatics, typically in bigger hospitals, you have one team of people that work on the hardware and on the infrastructure and the networks and the wireless Wi-Fi and the Wi-Fi and all the components that go with it. And then you have another team that works on helping the electronic medical record work right, teaching staff how to use it, making sure that we're supporting our doctors, and making sure that we're staying current with all the changes. And we have had a variety of different people help us over time. When we first started, Diana Trechter was one of the nurses that was actively involved with us helping get that started. We've added other people who've come and gone. We now have Lisa Herndon, who has been functioning in this informatics role, but we can't rely on just one person. So we are looking at interviewing. We have one position open, and it's possible that we may have to have two. Because time and again, one of our biggest problems for our physicians, and if you recall, we struggle with meeting our meaningful use, largely because of the lack of support for our doctors. And they're busy seeing patients, we're trying to help them, but we need to have people right there helping them all the time. So we're looking, and it's not getting easier. I remember when we had the conversation about how many staff are we going to need when we bring on CPSI, and at that time we had one. It seems like it's a never-ending expansion of service. And the reality is we can't do it with less. And no matter how hard we try, what ends up happening is we stumble. And we buy something, we try it, and we just can't get past that, no matter how we try. And the times that it's hard for caregivers to be able to use a system that's not what their focus is. Their focus is on taking care of patients. Time and again, our medical staff has said, don't make these changes unless you've got somebody to support us. You've heard it, I've heard it time and again. So we're looking at finding, and we've struggled finding people that are good at it.
You know, when you're up in Salem, I know that the doctors get a $5,000 Oregon tax credit for being in rural areas. I was wondering if while you're up there, you could throw your weight around with the Oregon legislature. Suggest that the RNs also get a $5,000 tax credit.
It's an excellent suggestion, and I will certainly try whatever weight that I've got to encourage that. I can tell you that $5,000 tax credit comes up for review just about every year, saying, is it really worth it? It is important to us. If you're in an urban setting, don't necessarily agree. But it is there are other kinds of benefits. But that's a great suggestion that we try to do.
EMTs get a $250 a year.
Yeah, the deduction of $250, not a tax credit. But a deduction is good.
That's an excellent suggestion. One of the things that you saw that Patty talked about in terms of our compliance is the charge master review. And we have our charge master reviews in February 16th, so a week and a half. So this is an annual program that we do. We look to make sure that we are charging appropriately. We've had, I think last month we had people asking about that. Is it appropriate? We need to make sure that we are doing all that we can to charge appropriately. Not overcharge, not undercharge. So that will be going on. Lakeview Gardens, the construction project. It's a never fast process, God bless you. We're receiving bids right now. We just are handling city permits. Looks like that review might be finished before the end of this, by the end of this month. We've sent them, the architects and the contractors have sent those to the city. But remember, that review is done in Climate Falls. Then you have the state review. The state is saying between 4 to 8 weeks. We'd have no idea how quickly they'll move. It's anticipated that we will have by the 19th, so maybe by our board meeting, then an estimated or a guaranteed maximum price. We'll see if that's their target date for right now. Once we have that, that's when we would then be able to go back to Washington Federal and get the loan guarantees that we had. Remember, they needed to have that before they moved on to the next step. We still don't have our certificate of need. Remember, we applied for an expedited review. We paid close to $50,000 for that privilege. That was supposed to take 4 months. We're into the 8th month, and we still don't have an answer. We have the same issue of what do they do with the extra beds. It's a very frustrating process. I talked on Monday or Tuesday with the Weinberg, it was Tuesday, Weinberg Foundation. Said, we had not submitted our final plan because we didn't have our audit completed, and we needed to have the audit completed. Plus, Adam still has not finished that. What Weinberg said is, submit your application. We'll be okay without it. You can send the audit secretary, so we will be doing that. Wish I could tell you that it's going faster. I'm trying to push it as fast as we can. Do you have any questions about that?
Can we get our expedite fee back?
Well, they're very proud of that. Thank you very much. We are, the audit meeting is supposed to be on February 19th. As of this point, there'll be 2 presentations, one for the Goose Lake Lakeview Gardens, the other for the district. Some of you can't be there, some of you can. We'll get the electronic version out to you and paper if you prefer, as quickly as we can. We've seen the draft copy, but it has not been finalized yet. Tomorrow, Jane and I are going to be going to Phoenix. I'm told the weather will be nice. I don't know. Probably not. This is the National American Hospital Association World Health Conference. And I think there will be about 25 people or 25 representatives from Oregon hospitals at this meeting. So there'll be several presentations and lots of good education. This is a big deal. So, Jane, thank you very much for taking the effort to do that. I said I'll be out in Salem the week after to promote this position, our position of transformational funding. And last, we were granted $47,304 from the Eastern Oregon CCO. $19,028 for the health promotion, and $28,276 in another kind of program. This is something that Mira is working on with through our CHIP program. We'll be talking and focusing on encouraging adolescents to come in, be seen in the clinic, working on healthcare there, and empowering girls. It's a test program, young girls to take better care of their health. And we're very excited about that. As it turns out, the dental sealant program that we started last year was, because of the success of that, is now being extended throughout all of Eastern Oregon through this CCU. Because it really is a great program. Do you have any questions I can address? Concludes my report.
Thank you, Charlie. Do we have some executive session items?
Unless you would something you'd like to cover.
Well, in that case, we can probably adjourn. We are adjourned.